And I welcome reactions, challenges too, because I think that's where we all learn best.
I'd like to start then. Could you just spend a minute or two on how you get to the with, when you're actually working with executives and clinical leaders, how you get them down that journey other than just making them feel they need to do it?
Yes, brute force would be one option. I just have had the pleasure over the past year of working with 48 teams from across the U.S. who are working on improving patient experience, because there's a lot of attention in the U.S. I don't know if you're aware of it. We have a national metric, I think you know of. And within 2 years, a very substantial portion of payment to hospitals will be based on those results. And it's a zero-sum game. You get, others lose. So you want to make sure you're on the gain end of it. So a great deal of attention. So that financial payment helps. But what really helped was simply changing one key behavior, which is having a patient and family member sit at a table about anything. I don't care what it is, preferably something substantial. Menu in the cafeteria may not be what I would consider substantial, but getting started. And people worry about, well, how do you get the right patient and family advisor? How do you get the right person? I think everybody imagines the family from hell. And I warn people, if I'm ever hospitalized, here's what you can expect. Otherwise, this will be the family from hell behind me. And so I think find someone, ask some of your physicians, others, of who's a really knowledgeable patient who you think would help us with this one project. Don't try and do everything, but just start that behavior. Usually, almost always, the experience is one experience changes the day. You build on that. So start small, ask, engage someone, and work on a topic together. Some of my colleagues were working on a patient education approach to something, which is kind of a safe, neutral thing, and saying, does this make sense to you? Can you read it? Do the words make sense? What about the layout? Great way to start. And then build from there. The other is, if any of you sit on boards or have policy influence at an institution level, the idea that we would start a new program or a new service without co-design from patients and families is unconscionable. And I don't include focus groups as co-design. Nice, that's in the doing with stage, but not sufficient. Yes.
Thank you, Barbara. That was a great talk, and it's an area I'm quite passionate about. So the question that I have is, what's your experience in terms of staff being able to actually move to that kind of mutual decision-making? Does it take a lot of skill building in order to move forward?
Right. And when you mean staff, do you mean like all of us in the care, so nurses, physicians, respiratory care practitioners? Is that who you're meaning, the whole scope of us?
Yeah, the whole team.
Great. And I think you're supposed to say who you are and where you're from.
I'm sorry, yes, Neil just pointed that out to me. I'm Sharon Goodwin, VOA in Canada.
Okay, great. Yes, and it requires enormous skill development. To presume that we can go from doing to doing with in the leap, it's sort of like Superman, leaping tall buildings. It's not possible. Leadership's accountability is to develop the infrastructure and the improvement to make sure it happens. So when I sort of deride my colleagues, RNs, who struggle with bedside change of shift or bedside connections, or physicians who are not doing multidisciplinary bedside rounds in a hospital, for instance. That is a big skill development. And for most of us as professionals, the risk of not looking expert, of doing something wrong, is a huge fear. It's a huge fear. It's a valid fear. But we tend to overgeneralize. It's as if a patient won't be forgiving if we misspeak. So there's a great concern that I might do something wrong. So I'm a great fan of really fast simulation, practicing it, and then building on that, improving it slowly but surely. So skill development, particularly in that communication, being with someone, is a skill set. Many of you are probably familiar with some studies that show that if physicians listen for 2 minutes to the patient narrative, to the patient story, they will get almost everything they need for an accurate history and pretty close on the way to an accurate diagnosis. The average physician in this study waited 17 seconds before interrupting, which means there was a few that went, a little bit longer than 17 seconds, and then those outliers who didn't wait at all. So there's some very basic, not really hard, don't take a lot of money kind of tools that can help us.
That's great. Thank you.
I'm Larry Chambers. I'm on the board of the Change Foundation too, but Kathy left me out. I was wondering about patient advocates. You mentioned that, and it's my view that, especially in a publicly funded service, that we'll never be able to pay for all the health professionals we'd like to have. And there are some really good examples of organizations that have mobilized volunteers, if you want to call them that, or health champions. In the UK now, they've trained about 75,000 health champions. I was just in Sudbury, and there's a program called the HELP program for geriatric care that came out of Boston. And they had 2 wards for geriatric services, and they had 40 volunteers that they were working with. It just seemed that that's a very consistent theme with your kind of care.
Right. What we get into, as long as we carry a professional, institutional, or organizational perspective, is we're the ones that has to do it. And so we ignore the resources among us. And I think we have wealth beyond measure as far as the resources for health and healing. We just use them in the wrong places. We don't use the right folks with the right set of skills. And I absolutely endorse what you're talking about. As a matter of fact, I mentioned my colleagues in South Central Foundation in Alaska. They have trained a wonderful, amazing network of community health workers who, in many ways, substitute what would normally be done by a physician in the lower 48 states of the U.S. And they are doing very well with their health outcomes. So I think we convince ourselves in our country, what also gets in way is the licensing regulations of what a nurse can do, what a physician do. All of those are guild protection statements in my book rather than public health. So when I say big P to small p policy, when you start talking about licensing boards and changing that, the walls start to shake for some folks. So that's why it takes the kind of assortment in this room to make these changes.
Hi, Heather Dawson from the Health Council of Canada. Thank you very much for your presentation.
Yeah.
I'm interested in your thoughts on patient satisfaction or patient experience surveying. We do a lot of that in Canada, and we use some of the US tools as well. I'm, again, interested in your thoughts on how we can use that data to inform.
All right. How do you think you're using it now?
We are reporting back. This is what you're saying.
All right. What I see right now, and it's in that doing with kind of thing, we ask. We ask you, how'd we do? Oh, okay, that's what you said. Oh, okay, thanks, we'll work on it. And that's kind of where we are. It's an interchange, not a conversation. And we do in the U.S. love to chase numbers. So I see people who are chasing the numbers. And what I try and teach people is what you're looking at is the totality, the whole of what this is telling you as a story. So I'm a big fan of statistics and stories. If you're not hearing the patient's story, the statistics won't mean a bit of difference. So only in the context of what does this really say about our systems do I think is the best use of those surveys. Sometimes I see people think, well, we just asked the question a little bit differently. And if we just ask it a little bit differently, we keep collecting enough data, we might get the answer we're looking for, which means I don't have to really change as much as it really says I need to change. And the ones who make the biggest progress are those who really look at the data and say, wow, does this say something about us? And some things that we don't like. Now, what are we going to do with it, and who can we partner with to help us with that? And so the next step is, if you don't have patient and family partners with you, you get them to help you to understand, okay, what does this mean? Because it's never at a granular enough level to really take that specific action. So does that... So don't get lost use it, but don't get lost in it, and don't stay there and forget that there's a story behind it.
Hi, I'm Carol Kushner, Patients for Patient Safety Canada program of the Canadian Patient Safety Institute. I wanted to ask a question about the tension between standardization and measurement and the individualization that comes with a person's narrative and their personal experience.
Okay. All right. The only variation, this will be a fairly broad statement, but the only variation I think is totally appropriate is patient-driven variation. So if it's variation because that's how we as an institution choose to do it, or that's how, as usually in our case, as a professional I choose to do it, and nurses are as variable as physicians. In our country, we love to pick on physicians, but nurses are great at their own variations. If those are the sources of variation, then that I consider as primarily a source of waste. I also like to view that their standardization where it adds value, and value as defined by the patient. So I've gone through my era as a patient safety officer of being the standardization queen and driving colleagues crazy. I was having things standardized that made no sense. So how do we understand what adds value? Well, again, we look at how we do our work, what does it mean to patients and families, and pretty soon you cut through a lot of crap. Excuse me, stuff. A small example, I don't know, do you have whiteboards in your patient rooms? I would love to have been a whiteboard manufacturer about 5 years ago. Oh, God. Anyway, just a story from a chief nursing officer last week who said in their doing 4-stage, they designed a whiteboard, probably almost as big as this, with 13 elements on it in every room that nurses were supposed to fill out. And they had it standardized. How reliably were nurses filling out 13 elements every shift? We can guess that. And how many were crossing out saying, well, I don't use that, I use this one instead? They moved into the doing with stage, started asking patients and families, what's important to you? What wasn't the number for housekeeping? Why was the number for housekeeping up on this board? So if you had a concern about housekeeping, you can call housekeeping. That sounds a little bit like them doing our work for us, does it? So they got it down to 6 elements. That now is standardized, but it's standardized based on what they learned from patients and families, on what's workable. It's now more efficient. Nurses are getting it done. So again, patients and families in partnership help us do things better, faster, cheaper. And I'm always a big one for better, faster, cheaper. Other comments or questions? Does this make sense? That was the intent, but I want to make sure it does. Did it make sense to you? All right. Okay.
Hi, my name is Gail Forsyth, and I work with the Lynn Liaison branch of the Ministry of Health. And I'm just thinking, while you're talking about individual physicians or nurses, I think that there are individuals who do just what is ideal and others that don't. And again, just my stream of consciousness, I think that when people go to their family doctors, this is probably the kind of engaging discussion that you have with your doctor to say, well, I agree with this, or yes, I know you want me to take those meds, but I'd rather try this first, and you have a dialogue, you come to a decision, and if I feel this isn't working, I'll do it. But I'm wondering if it's something within the institution or within our training institutions at universities and medical schools that still actually promotes that attitude of, I'm the doctor, I have the most knowledge, and you somehow reinforce that. So unless it's leadership that's saying we want our physicians and to behave in a certain manner that is more engaging and respectful of family and patients, then maybe there'll be, I know, that kind of change. But I think that people do it. But I think it's, you either have, demanding and smart patients or families with good advocates, and you get the best that the system has to offer because you demand it.
Yeah.
And other people would not know or might be intimidated and don't get what they require.
Yeah. Your point is so great. It's so great that this is not about a general conspiracy that no one is doing the partnership work or hasn't wanted to do it or been doing it all along. It's what's the system and the environment that we create that nurtures it or inhibits it, that says this is the norm, not this. And I believe that our education programs are doing a really strong job right now, getting better, and they come out to our hidden curriculum, where in some of our settings, being respectful to one another is not the norm. Spending time to engage with the family, because it really does save time in the long run, is not the norm. So I agree with you, and that's what we've found in our studies of successful organizations who have great patient experience, is that leadership is there to make sure that there's the infrastructure, the improvement, and the values to act on these consistently. Because all of us know, yes, I might have a great experience with you, but I have a lousy experience 10 feet down the hall. And so it's how do we make that a consistent factor in all our organizations so that that's nourished, not the outlier. And often right now it's considered the outlier. Something that's nice to do when you get around to it. People, again, don't see that as integral to health and healing. Yeah.
Hi, Barbara. I really enjoyed your talk. My name is Sue Vanderbent, and I'm the Executive Director of the Ontario Home Care Association. Okay. But I am also an Associate Professor at McMaster University, and I teach in the DeGroote School of Medicine. And we have a very comprehensive communication skills program. In fact, I'm the domain planner for MAC's communication skills program. And not only do we take our students through a very extensive process of communication skills development, but we also take them through a 14-month process where they examine themselves, ethics, cool. Not their own ethics, their own motivations for wanting to become a doctor. We deal with a lot of the professional competencies that doctors really need in order to practice well and to feel strong and to feel in control so that they can work with patients and families as their team, because it's all about the team. So I want to let you know that cool. At McMaster, and I know in a lot of other Canadian schools, but certainly at McMaster, and I can attest to this, we pay an awful lot of attention to our students, and we've been doing this for the last 20 years because I've been on faculty at MAC for the past 20 years. Yeah. So, cool. So I think we are making changes. We also bring our students back because we are very aware of the hidden agenda. And we tutor them and help them in terms of how do they deal with the issues of authority and power and control, and how do they ask as a student and as a learner when they see something that's wrong, but how do they ask and how do they do it in a way that helps them maintain their own integrity, but also teaches the older generation. And I think there's a lot that we can learn from the older generation of doctors, and I think that there's a lot that the younger generation that we're teaching now have to offer. And I know one of our speakers is Danielle Martin, and she's also, obviously a product of new learning. So we are trying very hard in Canada, certainly at MAC, to do what you are hoping to see done. Well,
and I applaud you for that. That's phenomenal, especially the skills when you are newer in a setting. How do you influence that? Because that's where we can squeeze it out of them very quickly, and we can't afford to lose that. It's another wasted resource. So great, congratulations.
Thank you.
Hi, good afternoon. My name is Saul Malamed. I work with a group called the Lynn Collaborative, and thank you again for your talk. It's been excellent. I was listening to your talk about not having the patients do our work for us, and I've been reading about chronic disease prevention and management and how a lot of the work does rest with the client or the patient. I'm just wondering if you could talk a little bit about those
thank
two
you.
things.
Yeah, thank you. That's a wonderful point. Wonderful point. I differentiate between when we're in partnership, it's what do I, as a patient, or you as a patient, need to care for your own health and health care journey, and how can I be in partnership with that? That's a difference than in our organization, we're not doing so well, we need you to make up the gap. So a clear distinction, and thank you for bringing that up. So terminology that we use, which isn't very patient-friendly, but it's self-management support. Wonderful people, and there's some people in British Columbia who are doing amazing work there, colleagues in California, on how do we partner together to manage what most of us deal with, which is a multitude of chronic health conditions, things that will not be cured, which our acute care system is not equipped to handle. And so it's being in partnership to understand that and understand self-management support. And that body of literature and knowledge is, to many of us who have come through more of an acute care development, is almost invisible. And it's, again, another wasted resource. And for those who haven't quite gotten to that doing with that partnership mindset, we still think we in the healthcare are going to influence diabetes outcomes. And how wrong that is. We play a major role in that, but it's only in being partnership. So there's a difference that you pointed out, which is it is my health status, and my health journey in which we partner to make progress. Does that help? Does that clarify? Okay.
Hi, my name is Deirdre Walsh. I'm a health coach, so I work with individuals to manage their self-care, look at their beliefs, their motivations.
Yeah.
But I wonder sometimes with interacting with physicians and nurses, if they're concerned about whether patients will fail to understand the boundaries and whether they will want to, become more involved than the clinician actually has time for. And if you've ever had any experience with that.
Yeah. It is a concern that I hear. Well, if I wait for 2 minutes, they'll go on for 15, is a common one. And I don't mean to make light of that. What happens? And that's where the skill set has been pointed out here about how to be in partnership. In the doing with phase, according to how I see it, I see healthcare providers almost abdicating their role in the partnership, as if I give up. That, here's what I offer, but they didn't want to do it, and we didn't agree. Rather than how do we remain in partnership? How do we remain in conversation? So what if the patient is involved in a 15-minute narrative and we have a 10-minute appointment? What if the patient is not on the same path that I'm on? So all of those questions, and most often what I found in most clinical settings, you can distill it down to 3 or 4 or 5 common scenarios that we can talk about. So in working with nurses, what's your biggest concern about if we do this? If we do communication at the bedside rather in a conference room, that's a small little one that I use, but it causes big turmoil. So there's a children's book, I don't know if you know it, Mercer Mayer, The Nightmare in My Closet. And at the end, he lets the nightmares out of his closet, and they become buddies in the bed. What I like to do is say, what's the nightmare in the closet here? Let's put it out there. And then let's walk through systematically. Example I'll use is, if this doesn't get to it, just tell me no. Family presence. If you're used to, and because we've had a lot of rules in our healthcare systems, we sometimes nurture those of us who are rule-based, like my rules. And the overhead just said visiting hours are over, and if people aren't moving, I call and say it again, only louder, And so when we take our rule-based colleagues who have had the comfort, maybe the delusion, but the comfort of rules, and say we're not going to have those kind of rules, they believe that anarchy will reign. A little bit about the Vancouver celebration could come to mind here, but we won't go there because it's a sore spot. And so what we think about is, what are the skills, what are the infrastructure that help that? How do you understand who's going to be at the patient's bedside overnight? Because I'll get people saying, well, it's a security breach. How will we know who's in the hospital and who's not? And I ask, how do you know now? Well, we don't know. And they discover the number of avenues to enter a hospital at night. So as long as you can be in conversation, you will find the solution. So it's similar to what I say with partnerships with patients and families. We have to have partnerships with those in our institutions. That's a doing with. So it usually, again, distills down to what are those scenarios that frighten you most. Let's address those. Let's say you are dealing with somebody who's really spooky at 2 in the morning. What are you going to do? Because the challenge is, oh, sure, Barbara, you're home in bed. I'm the one who's here. All right, well, who do you call? Who is going to be there at 2 in the morning to address that? So again, it's not just saying, well, we're going to throw out all the rules. We're going to design effective systems. And talking with a group tomorrow, that great patient experience is a very disciplined, designed, effective system. Who designs it and the discipline we bring is defined in partnership. Does that help? Okay.
Can we make this the last question?
Sure.
Then we'll do a switch change.
My name is Rita Damiani. I'm from the Hospital for Sick Children here in Toronto.
Oh, good.
You mentioned that key decisions are mutual. And the question I have, or the challenge that I'm sometimes faced with, is how does this work when parents are representatives on a committee where they have one perspective? I see how it works on a one-to-one clinical basis, but that's the challenge that I would like to answer.
So your question, make sure I understand it. Your question is, you have a parent or a family representative on a committee, a team that working on something, and they bring one perspective. And it might be only their lived perspective. Okay. This is where you think about, it's very tough to be an only. So if you're the only one in anything, and you're supposed to represent others, of an age where I was the only female executive for a long time. I was the only female who wasn't a nun on a lot of committees. And so you feel a burden to represent your own lived experiences versus a collective. So usually my colleagues and I will recommend, first of all, don't have an only. Have 2 at least. All right. And secondly, this is where partnering with patients and families to understand the best match for individuals on the activities that you're looking for. Some people are able to represent a larger story, as my colleague Martha Hayward, who is with the Institute for Healthcare Improvement, and she's a breast cancer survivor, and they've hired her to lead much of this work in combination. She and I tag team on this. And Martha talks about being able to take your story and make it a universal story. And that comes with a skill level of communication, not just that makes us comfortable, I'm cautious about that, but that there's ability to move beyond your own lived experience, but to encompass talking with others, listening to others, bringing those forward. So the first most tangible thing I suggest is perhaps looking at having 2 folks, and 2, talk with them in partnership to figure out how you can get other voices represented in the work that you're talking about. So let's say you're designing a major change in a program. How can you partner with patients and families to seek a wider array of patients and families? Because I, as a nurse, can represent one thing, and I certainly don't represent all of nursing. So we wouldn't expect one physician, one nurse to represent the entire profession or the organization. How can you do that with patients and families? Does that help? And of course, my colleagues, I would be remiss in saying, the Institute for Patient and Family Centered Care, Bev Johnson and that team and their website is wealth beyond measure as far as resources for those types of questions and additional assistance. Thank you again.